In this lecture, we will discuss Klinefelter syndrome and Turner syndrome. These are genetic problems with the sex chromosomes. So let's start with Klinefelter syndrome. These patients usually have male hypogonadism. They have 2 or more X chromosomes and 1 or more Y chromosomes. Most commonly, 2 X's and 1 Y, like you can see in this patient's karyotype. This occurs in 1 out of 650 live births, so it's not that uncommon. This is generally due to maternal or paternal non-disjunction during meiosis as they're making either the sperm or the egg. There's a slightly increased risk of this happening in mothers who are of advanced maternal age. Sometimes Klinefelter syndrome patients are fertile and can go on to have their own children. Fertile Klinefelter syndrome patients have a low recurrence of Klinefelter syndrome in their offspring, but the offspring do carry a very small increased risk of chromosomal abnormalities. So let's review the clinical features of Klinefelter syndrome. They often suffer infertility. They may have hypogonadism with small testes. They often have gynecomastia in adolescence as a result of an imbalance between testosterone and estrogens. You'll notice they have reduced body hair. They will be tall and have a pear-shaped stature to them. And they occasionally have educational and psychological problems. So how do we diagnose Klinefelter syndrome if we suspect a patient might have it? Well, first we will send a karyotype or an array comparative genomic hybridization. This will make our definitive diagnosis. We will also screen these patients when they are adult males for infertility. That's useful for them to know about, for often they have a decreased sperm count. It's important to check their testosterone levels. They will often have a decreased testosterone in the face of hypergonadotropism. In other words, they have hypergonadotropic hypogonadism. Their testes are non-responsive to LH and FSH, so they have high LH and FSH hormone levels. So how do we improve these patients' lives? The first thing that's very important is they should receive testosterone therapy. This will help a number of things, especially their facial and body hair issues. It will improve their strength and muscle size. It will improve their energy level. It will help them with libido issues. It will help them with confidence, and it will help them with concentration. So we often will refer these patients to reproductive specialists or infertility specialists as well to help them with various reproductive options if they should decide to have a child. So let's focus now on Turner syndrome. Turner syndrome is a partial or complete monosomy of the X chromosome. This results in hypogonadism in the phenotypic female. The incidence is about 1 in 2,000 live births. So how does this happen? Well, more than 60% are due to a de novo meiotic non-disjunction in the paternal sex chromosomes. So the dad has an X and a Y, and instead of splitting into 1 X and 1 Y sperm, there's basically an XY sperm and an empty sperm. And the empty sperm now then goes and fertilizes the egg, creating a single X chromosome. Turner syndrome occurs essentially only in females. Males can be mosaic for Turner syndrome. This is rare, but it can happen, where a male has some cells that are 45X and other cells that are 46XY. So what are the symptoms in females of Turner syndrome? These are important to remember. These patients will have a delayed puberty. They will often have amenorrhea. This is from gonadal dysfunction. They may have premature ovarian failure. This results in infertility. And some patients may have some learning disabilities, especially in math, but generally these patients are cognitively normal. Patients with Turner syndrome may have short stature. In fact, they almost always do. They have low set ears, a low hairline, and you may notice a webbed neck or a broadened neck root. Additionally, you can see small jaw, a shield chest, which is a broadened or widened chest, often with widened spaced nipples. You may see cubitus valgus, or outward turned elbows. They may have a horseshoe kidney internally, which they may not even know about, and they can develop congenital heart disease. So, how do we test and when do we test for Turner syndrome? You should consider attempting prenatal diagnosis if the fetal ultrasound shows intrauterine growth restriction, fetal edema, a coarctation of the aorta, or cystic hygroma. In this case, if a parent wishes to do prenatal testing, we generally do chorionic villi sampling or amniocentesis with karyotype. Postnatally, the diagnosis is made by karyotype or ACGH, just like in Klinefelter syndrome. So, what therapy do we provide these patients? After initially making the diagnosis, we will screen them, generally with an echocardiogram or a renal ultrasound, especially paying attention to any abnormalities of the heart, such as aortic problems, or if there's an abnormal kidney. Additionally, we will typically check them for their thyroid function, we'll do an eye exam, and we'll assess for scoliosis, which is a little bit more common in these patients. It's important to refer these patients to a pediatric endocrinologist for hormonal replacement. These patients will receive estrogen, progestin, and growth hormone. If you look at this picture, here are two patients with Turner syndrome. The one on the left received no growth hormone, and the one on the right received growth hormone. Growth hormone is indicated in these patients and can really help them in terms of achieving an important stature. The reason why we give it is because for patients who don't achieve 5 feet of height, this can result in significant impairments in their ability to function in the world. It may be simply hard for them to drive a car. We want these patients to live the most fulfilled lives they can. It's also important to refer these patients to fertility specialists for consideration of their reproductive options when they enter into adulthood. So that's my review of Turner syndrome and Klinefelter syndrome. Thanks for your time.